Very good morning to one and all present here. I am Debolina from Clinic. We are very much proud to be a part of this webinar as a digital partner. Clinic is India's largest live digital CME and doctors generated medical content platform. So here is a short glimpse of Clinic. Thank you so much all for your patience. You can always find us on Google, which is www.clearnet.com. We have lots of live sessions conducted by eminent speakers across the globe. We have MedWiki services, which is medical Wikipedia for doctors. You can read them. In your leisure time, you can play pools and quiz. Besides, we have telemed service also. So you all are invited to visit our site. So now, without further delay, I would like to hand over the session to Dr. Makhan Shah sir to start with the session.
Both to me and Dr. Ghosh.
Yeah, over to you, sir, and Parthasarathi sir. Please proceed.
Good morning. Today we'll have a ward round scenario discussion on post-op pyrexia, which is a very common post-op problem, and also asked in the ward round scenario. Dr. Snehashish Nath will face the different scenarios, and Dr. Parthasarathi Ghosh, who is the associate professor of surgery at Diamond Harbour Government Medical College, will moderate this session. Dr. Ghosh, you can share your screen and start the session.
Good morning, everybody.
Good morning, sir.
Good morning. I think you can see my screen.
Yes.
So let us start with our first case scenario. A 65 years old gentleman has undergone.
Next slide. Dr. Ghosh, change the slide.
Sir, can you see the slide?
Next slide is not coming. First slide is there in the screen. Yes.
And the problem is that it's not running in the slide share mode actually.
Okay, it's visible. No problem.
Okay, fine. A 65-year-old gentleman has undergone radical cholecystectomy. He's a chronic smoker and has COPD. He's on IV fluids, getting epidural analgesia and injection cefuroxime following the surgery. Now, in the ward round next morning, the records revealed that his body temperature is raised for last 12 hours. Last three records are like 99.9, 100.4, and 99.8 respectively. Respiratory rate is 22. Saturation at room air is 97, and pain score is 7/10. Now, how we can address the parameters?
Yes, sir. So the fever has occurred immediately within the first 24 hours following the surgery.
Yeah.
So it is a case of maybe a case of immediate post-operative pyrexia, sir. It may be due to metabolic response, or as because this is a radical cholecystectomy. So most probably the patient underwent blood transfusion during or after the surgery. So it may be a blood transfusion reaction. The patient is being given IV cefuroxime and other medications. So it may be a drug reaction also. And
what is another important cause of pyrexia in the first post-op day? Very important criteria. These elderly gentlemen.
From anesthesia point of view, sir, malignant hyperthermia may also.
It's not hyperthermia. It's not. You see, the temperature is shown. It's not
yes,
a temperature.
100.4.
Yeah. It's not malignant.
Yes, sir. It's just touching the.
You see,
the guidelines.
You see, there are some clear conditions of fever in different post-op days. 1 to 2 days, 3 to 5 days, 5 to 7 days, and any time in the post-op period. So there are some defined areas. You have mentioned about the metabolic fever because of transfusion. Apart from this, there is another term. What is sterile aseptic fever?
Sterile aseptic fever, sir. This can also be known as febrile non-hemolytic pyrexia, sir. It occurs with fevers with chills and malaise. It occurs 1 to 6 hours post-surgery.
Okay, Dr. Ghosh.
Okay, fine. Whenever we get into such a scenario, the first thing that comes in that appears in our mind or comes in our mind is whether it is a metabolic response to the injury or some causes, or it's an infection or some post-operative serious complication, right? The first thing, so there is a big list actually for the causes of post-operative fever, and it's very common scenario. But of course, you are absolutely right. A mild pyrexia in the post-operative period may be a feature of normal response to the tissue injury or a metabolic response to that surgery. And I think only relatively few only actually go into any infection or like that. Maybe if we are dealing, if the temperature is not that high, so maybe we are dealing with a case of metabolic response to injury, or we are probably beginning with some complications. Now, in the next morning, I mean, in the second post-operative day, and one thing is that the patient was on epidural analgesia, so he was not receiving any sorts of NSAIDs or paracetamol. So, might be the metabolic responses are over. Now, in the next morning, when we are in the round, the temperature is still 101 degrees Fahrenheit, and it's persisting for the last 24 hours. Now, do you consider it as a significant rise of temperature, Snehasi?
Yes, sir. This is a significant rise in temperature, as this is a post-operative day 2, sir, and patient is, as in the case scenario, it is mentioned that it's a known smoker and is patient of COPD. So there may be chance of development of atelectasis. Actually, atelectasis doesn't develop, usually doesn't develop in day 2. It usually develops on 3rd day onwards, sir. But
No. At least it can develop as early as 6 hours post-op.
Okay, sir.
Actually, it doesn't come 48 hours because of upper abdominal surgery, COPD
yes,
already
sir.
patient, so it can come immediately after the 6 hours following operation.
Yes, sir. Atelectasis may also be a cause.
So, Snehasi, just to interrupt you. So, we may get some it may be because of some non-infectious causes, like the components of the inflammatory response syndrome because of the surgical intervention, and atelectasis may develop in in this period. And but if it is for any significant cause, what we need to observe actually that the temperature is on the higher side if it is significant, number one. Number two, they're usually associated with a moderate rise of WBC count or leukocytosis 3 or more days after operation is persist. That means and typically they are persistent. So if you have a persistent rise of temperature over 1 to 2 days or 3 days, that becomes significant to us, and we really need to think whether what is the cause for this rise of temperature. Now, if you consider, I'm supplying you some more information that the respiratory rate is 24 per minute, the SpO2 at room air is 94, and on auscultation there are some diminished breath sound on the right lower chest with fine wells present over there. Now, what is your thinking?
Sir, the same atelectasis might have occurred in this patient, sir.
What to do?
Sir, treatment is for atelectasis.
Before treatment, how to confirm? Before treatment, need confirmation.
Yes, sir. It is confirmed by thorough clinical examination and chest radiography, sir. By simple chest X-ray PA view, we can confirm the atelectasis or its further progress of the disease. And I would like to perform certain blood investigations for that, sir.
What blood investigation you want to perform?
Sir, complete blood count, preferably, but also it can be done total count or differential count.
Now, total count remains, suppose 13,500, and the neutrophil is 81%.
Yes, sir. Then it is definitely due to, sir, bacterial infection, sir. as because total count is raised and the neutrophil count is also on the higher side. So maybe bacterial infection, maybe in the background
But
cause.
your chest
So-
X-ray shows
Yes, sir.
a collapse of the right basal lung on.
So what might happen after atelectasis if you have a count being raised and neutrophil is high? What does it indicate? Is simple atelectasis or something else has developed?
It is, sir. It's going towards, sir, pneumonia, sir. If the atelectasis remains unresolved, then first there is, sir, occurrence of pneumonia from unresolved atelectasis. There might be in symptoms. There might be
And
respiratory.
Shansis, don't get focused only on the respiratory.
Yes,
Patient
sir.
has got
Yes,
high
sir.
leukocyte count. It
Yes,
is
sir.
time to think is atelectasis only or patient is having, because it's a major surgery.
Yes, sir. Sir, SIRS, systemic inflammatory response syndrome, might also have been occurred as because heart rate is more than, sorry, sir, respiratory rate is more than 20, and WBC count, as sir told, is 13,000. That is more than 12,000. So any of, I mean the four criteria, the two criteria are fulfilled for stamping this patient as a SIRS. So two criteria are fulfilled. So SIRS can be diagnosed on the basis of these clinical parameters. Sir.
SIRS is not a diagnosis.
Sorry, sir. This clinical
SIR is a
condition.
manifestation of some underlying problems.
Yes, sir. Yes, sir. So in the treatment, sir.
So Snehasis,
Yes, sir.
of course, in the second post-operative day of a radical cholecyst following a radical cholecystectomy, the patient is in SIRS and the chest X-ray shows the signs of small collapse in the right basal zone. So, of course, at least we are dealing with the case of atelectasis. We really don't know whether this patient is having a pneumonia. Right. Now, how to deal with this pneumonia? What advice will you give to the patient?
Sir, I
To
will,
overcome the situation.
sir, I will ask for incentive spirometry, sir, and also semi-recumbent position of the patient, and also, sir, I will add chest physiotherapy. If the department is available, then it's fine. But we can also give chest physiotherapy in the ward itself. So
what is important is actually what is
antibiotic coverage, as you already mentioned, sir. It is already covered by hydrogenase and cephalosporin. So
what antibiotic you want to give? Cefuroxime is second generation.
sorry.
Whatever. Post-operative, I mean, the pulmonary complications actually start at the earliest. That means from day 1 to day 3. Now, if we consider thoracic and abdominal surgeries and atelectasis, actually there is decreased functional residual capacity following these surgeries. And if there are high risk factors like COPD, emphysema, if the patient remains smoker, we can get atelectasis in the form of fever, tachycardia, decreased saturation, accessory muscles are working, breath sounds are absent or reduced, and sometimes there are some rest. So you go for a chest X-ray. Now, what is important? Here is actually that atelectasis may be reversed in the first 24 to 48 hours. Number one is to control the pain. So you have to control the pain properly. You should have asked me what is the pain score of the patient. This is number one. We have to relieve the pain, number one. And number two, of course, you have suggested early mobilization, deep breathing, 5 to 6 sequential deep breaths, with head for 5 to 6 seconds, incentive spirometry, cupping, chest physiotherapy, like this, what that you have mentioned. So atelectasis is a non-infected situation and which can resolve by proper pain control and early mobilization and respiratory exercises given to the patient. So this is very, very important. So whenever you smell that it might happen, you have to jump into all the measures that you can take. Now, you are managing with the suspicion that the patient is having atelectasis. Now the temperature has gone up in the post of day 3 and the respiratory rate is 26. The patient is having a mild cough and there is bronchial breath sound as well in the middle zone of the right chest. Now, what is your, how will you manage or tackle the situation?
Sir, in this scenario, I would like to send sputum culture for this patient, sir, as because this is a case of unresolved atelectasis, and the signs and symptoms. I mean, the respiratory rate is increasing and temperature is also on the higher side, sir. So there must be a suspicion for development of pneumonia, sir. This is POD3. So I would like to send sputum culture for this patient, sir.
So we are dealing with a case of post-operative pneumonia.
Yes, sir.
Isn't it? Yes.
Yes, sir.
Now, in a post-operative pneumonia, actually, it happens in two forms. Either whether we have to consider whether the patient is intubated. If you think that this patient is intubated, and in one scenario the patient is not intubated, in one patient is on ventilator and the other patient is not on ventilator, what is there any difference in the approach? How will you identify? How will you think the diagnosis will change anyway?
Sir, in the ventilation, sir, there is more chance of infection, sir.
What that infection is called? What that pneumonia called?
Asymptomatic is organism, sir. Ventilator associated. Yes, sir.
Yes. So either you get a hospital acquired pneumonia, which happens in between 48 to 72 hours after admission, or a ventilator associated pneumonia. So post-operative pneumonia can be hospital acquired, or it may be associated with the ventilation itself. Am I right?
Yes.
Fine. So what is important actually now, the mortality rate is very high. So fever, leukocytosis, and new pulmonary infiltrates which were now present before the surgery will always poke you for the diagnosis of post-operative pneumonia. And if the patient is on ventilation, you have to look for the purulent respiratory secretions in the tube, the temperature, leukocytosis, and hypoxemia. Right. So in this, by this too, you can diagnose whether you are dealing with a case of post-operative pneumonia. Now, if you go for a chest X-ray or CT is not initially actually done. So if you go for a chest X-ray, you will get the signs and the signs of consolidation, and you send the sputum not only for culture sensitivity but for Brownston as well, because we're going to get the culture sensitivity, which will be delayed, and you have to put the patient on empiric therapy. So in this particular patient, you want to change the antibiotic. The patient is on cefuroxime.
Yes, sir. I would like to upgrade the antibiotics, sir.
When? You will upgrade empirically or you wait for something?
Sir, the sputum culture report will take at least some time to come, depending upon the lab scenario. Until then, I should start the upgradation of the antibiotic, empiric antibiotics.
What antibiotic? What organisms you were suspecting in the post-operative pneumonia? If you consider a community acquired pneumonia, and if you consider a hospital acquired pneumonia following a surgery or a VAP, what is the difference between the organisms? Is there any difference?
Sir, gram-negative organism.
Yes.
Maybe they...
So the majority of the post-operative pneumonia cases are actually caused by the gram-negative organisms, and there are cases where it is done by the caused by the gram-positive bacilli, and there you get staphylococcus. And in case of that, they are mostly in more 50% of the cases they are actually polymicrobial. So you have to keep this in your mind. So, sir, what sir was asking, that you have sent for the Gram-stain. So if you get the Gram-stain report, and if you have gram-negative organisms, then you can take the patient, I mean, you can put the patient, escalate the patient to piperacillin tazobactam or like this, and you can change your policy after you get the culture sensitivity report. So as soon as possible, you have to escalate your antibiotic therapy. Otherwise, you cannot actually manage, right? But remember, in early onset VAP, which is for the less than 4 days of post-intubation, you are safe. Actually, the organisms are usually antibiotic sensitive. But if the VAP develops in the latter stage, they are mostly caused by drug-resistant bacteria. And if the VAP develops in the first 5 days, the chance of mechanical ventilation, there is more chance of development of VAP. That you have to keep in your mind. So, with the idea of gram-negative organism, you need to remember that you need to advise what antibiotic you are going to give. Now, let us come to the case scenario 2.
Just one question. Just one question.
Please.
These post-pulmonary complications are preventable. How do you prevent pulmonary complications coming up in the post-op period? What are the measures?
Sir, early spirometry, sir.
Particularly upper abdomen, early spirometry. What else?
Early spirometry, and if possible, sir, nebulization can also be added for this patient, and early mobilization.
You're not talking about the more important thing. Upper abdominal surgery, patient diaphragm is splinted. Why?
Yes, sir.
Because he has pain on respiration. So most important is
pain
good
management.
analgesic.
Yes, sir. Yes,
you
sir.
should
Pain
provide
management.
good analgesic. Unless if you don't provide relief of pain, patient will not take deep breaths.
Yes, sir.
So one important is good mobilization of the patient, early mobilization. Don't keep the patient supine in one position within 6 hours. Patient will develop atelectasis. So frequent change of posture.
Position.
Patient needs incentive breathing exercise. Good analgesics. There is no role for prophylactic antibiotic just to prevent atelectasis. But if your surgery dictates that patient requires some antibiotics, that should continue.
Okay, sir.
There is no role for giving prophylactic antibiotic to prevent atelectasis.
Okay.
It's basically a chest physiotherapy, pain relief, and early mobilization. Okay. Case scenario 2. Yes.
So right. So this is the slide that I've already shown. That pain management, early mobilization. This is very important. What Sarah has told. So everything is preventable. Of course, the prevention is the best treatment for post-operative atelectasis and pneumonia. Now, a 74 years gentleman with diabetes mellitus, COPD, and an enlarged prostate has undergone hernia repair for bilateral hernia. The right side was actually a total abdomen, and he required a urinary catheter for the drainage in the post-operative period. He is also getting nebulization. Now he has developed fever of 103 degrees Fahrenheit with chills on the third post-op day.
Yes, sir. Sir, as the fever is a high grade, sir, there must be suspicion for urinary tract infection, as because the patient is already put on the Foley's catheter, and he has underwent inguinal herniaplasty operation. So first suspicion, I think this is a case of urinary tract infection, sir. There might be other causes as well. We have to rule out those causes.
Like what? You see, you have been given a guide of urinary catheter being there. So on third post-op day, there are some other important causes. You see, the fever is chill and rigor.
Yes, sir.
If fever comes with chill and rigor, there are some other conditions which can come up in the third post-op day. What are those?
Sir.
Don't get biased only with the catheter and UTI.
Okay, sir.
Other causes?
Other causes, maybe, sir, as because the patient is a known case of diabetic mellitus and COPD, sir. So chest infection might also have occurred, or phlebitis, or sir, so chest infection, UTI, and phlebitis, sir, which might be the causes, sir.
Okay.
Right. So you have to look for whether there is any phlebitis. Excellent. Now, chance of chest infection, though the patient is high risk, but it's a lower abdominal surgery, so chance of chest infection is low. But of course, you have to sense the patient is diabetic and the patient is having harboring urinary catheter. So you need to look for whether the patient is having urinary tract infection. For this,
Yes.
what you want to do?
Sir, I'd like
How
to
you want to
send,
manage?
what about wound infections at this stage?
Sir,
Is it common to have wound-related complications leading to this sort of fever in third post-op day?
third post-operative days,
Usually, it is little delayed.
little
Usually,
delay. Yes, sir.
wound complaint comes on after 5th day.
Fifth
Okay.
or fifth, yes, sir.
It may
Fifth day.
happen. You see,
It may
it
happen.
may
Yes, sir,
happen,
definitely.
but usually it is around 5th or say 6th, 7th post-op day. Fine.
Yes, sir.
Okay.
Yes, sir.
Carry on.
Yes, sir. Sir, in the management, sir, I would like to send the urine culture and sensitivity, and also the blood count, sir. And also, we'd like to perform the chest X-ray PAVU for this patient.
Now the chest X-ray is clear. The blood count, again, it is the TLC is 13,000.
Okay,
The
sir.
neutrophil is again 80%, and
Yes, sir.
in culture, I mean in the colony count, it is suppose 10 to the power 10 to the power 3 or 10 to the power 4.
Okay.
What is your idea?
Sir, 10 to the power 3, sir.
10 to the power 4.
Yes. Okay, sir. Sir, I would like to update the antibiotics, sir, and wait for the culture.
Now, do you diagnose this patient as a case of UTI?
No, sir. It is not more than 10 to the power 5, sir. Is considered a significant bacteria or UTI. So, as because the count is 10 to the power 4, sir, I will wait and I will sequentially monitor the patient.
So, you have uttered one from that asymptomatic bacteriuria. So, what? Yes, how to differentiate between a case of asymptomatic bacteriuria with urinary tract infection in the post-operative? That is very important. You have
yes, sir. Yes,
just
sir.
hit the point.
Yes, sir. Sir, in asymptomatic bacteriuria, the patient might not have fever due to urinary tract infection, but in UTI, the fever is high grade with chills and rigors, sir. And there may be other causes of other urinary sign symptoms like urinary burning sensation or.
So for diagnosis of asymptomatic bacteriuria, you need two criteria. You have to fulfill two criteria. One is microbiological and another is the clinical criteria, right? In microbiological, it must be more than equal to 10.5, right? And
yes,
in clinically, the patient must remain asymptomatic. But yes, when a patient is harboring a catheter, it's very difficult to differentiate between the symptoms
urinary
of UTI. Yes, but of course, a fever tells something else, right?
Yes,
but for
yes,
a catheter-associated, yes, a catheter-associated urinary tract infection, again, you need to have two criteria. One is bacteriuria, and at the same time, the patient must be. The patient must be symptomatic, either in form of fever or whatever, right? But here is the difference. If you can see in the new edition of Addison's textbook, now in case of catheter-associated UTI, 10 to the power 3 is an adequate count for U, which remains must be 10 to the power 5 in case of yes, asymptomatic bacteriuria. So this count difference that you must keep in your mind. Am I clear? So if you get a higher count, of course you need to address. Now if you have proved that yes, this patient is suffering from UTI. Now what you want to do? Do you want to keep the catheter or want to change it?
Sir, I would like to. As the patient has underwent inguinal hernioplasty and it is POD3, might be the patient is a case of prostatomegaly, but with adequate, the urinary support medications. I would like to remove the catheter.
So, of course, when you are dealing with a catheter-associated UTI, the catheter should be changed. But again, what Sir has emphasized in the last case, that prevention is the best treatment in case of post-operative complications. So you only do catheterize the patient where it is absolutely necessary, and try to remove the catheter as early as possible, if it's
Yes,
possible within 24 hours, if possible, right?
Okay.
So you try to remove the catheter, and you have to, you have to give the patient proper antibiotics to treat the scenario. Now, in general, though we generally give antibiotic for 3 to 4 days, but here in general we have to give antibiotic for 7 to 14 days to control catheter-associated UTI, right?
Yes, sir.
Now, case scenario 3. Sir, anything to add?
Yes, all right. Yeah.
Case scenario 3. A 13-year boy has undergone surgery for appendicular perforation.
Next slide.
Sorry. A 13-year boy has undergone surgery for appendicular perforation. On the 5th post-operative day, when you went to remove his abdominal drain, he was put on a drain during the surgery. When you went to remove his abdominal drain, he has raised body temperature of 102 degrees Fahrenheit. Now pulse rate is 104 per minute, pain score is 7/10, and he has an abdominal drain in situ, of course. And what to do now?
Sir, that's because it is a case of appendicular perforation, and it is a post-op day 7, sir. So there
Fifth.
must be 5th, sir. Sorry, sir. So there might be a chance of wound infection or sir, anastomotic leak, sir.
Anastomotic appendix. What is anastomotic?
Appendix, sorry, sir. Or any intra-abdominal abscess, sir, might have also be the cause, sir.
What is your diagnosis? Why you were thinking that? What is your diagnosis first, please?
Sir, wound infection should be the first.
What term we use nowadays? Do we use wound infection?
No, sir. Surgical site infection, sir.
Yes. So that if you say that the patient might have more chance of having a surgical site infection, you have covered a lot of area, right? That you generally do not cover with the terminology wound infection. So what are the types of surgical site infections this patient might have?
Sir, surgical site infection, actually infection at the surgical site within 30 days of surgery, sir.
Now, what are those?
What are those? Surgical site infection may be of different types.
Yes, sir. 3 types, sir. Superficial incisional surgical site infection.
Yes.
That involves the skin and subcutaneous tissue, sir. It may be deep incisional surgical site infection, which involves fascia and muscle. It may be organ or specific surgical site infection, which involves organ.
So the patient might have infection in any of these layers, right?
Yes, sir.
Now, suppose this patient is having a superficial surgical site infection. How would you like to manage that case?
So superficial surgical site infection, I would like to remove the stitches of the wound. I would like to
remove all stitches. You remove all stitches. Why? Superficial site infection.
Not all stitches, sir.
So first step is, sir, the first step is to remove the dressing if it is there. Then what will you look for?
I will look for any collection or tenderness, sir.
Yes, the changes, the local changes. You must first examine the wound. Don't open the stitch first. You try to inspect. You have missed one thing, or you haven't asked actually. What is the pain score of the patient?
7/10.
7/10.
Yes, that is very important.
Good amount of pain.
Yes, the patient. Yeah. If you see the pain chart in the previous days, probably it was 3/10. Now the pain score has gone up. So now you also look for the changes that happen in that local area. Now, if you suspect the patient might have some infected collection inside or beneath it, then you remove 1 or 2 stitches required and you try to
drain the collection.
So what are the strategies? What are the steps that is followed to to manage a surgical site infection? Number one, you are trying to tell that it is the drainage of the source of the infection. Anything else?
A regular dressing and well antibiotic coverage for the patient to control the infection, sir. And also, I would like to, I also have to rule out any deep space infection.
How?
Fine.
How will you exclude a deep or spreading infection? What are the
Okay,
what are
sir.
the important parameters to diagnose that?
Yes, sir. Yes, sir. Sir, while clinical examination, sir, if there is tendency on deep palpation, there is
No, before
tenderness.
tenderness, in the history, what is going to happen?
In the history, sir, as because it is POD 5, so the patient may say that the pain was on decreasing, but it increases, and it is persistent, sir. The pain is increased and it is persistent.
And what he may complain around? Will it be confined to the site of the incision, or it can be
In the it can
spreading?
yes, sir. If it is a superficial infection, then the
No,
pain
I am
or
talking of
tenderness.
deep. I am talking of
Yes,
deep
sir. Yes, sir.
infection, which can
Deep
be spreading
infection.
infection, which can be
Yes,
necrotizing
sir.
fasciitis.
Initially, sir, the pain is localized, sir. But after some time, sir, the pain is generalized, and even on clinical examination, there might be some rebound tenderness or something like that. As because this is a case of appendicular perforation, sir. So, deep infection, the pain is, sir, initially localized, then it is generalized, sir.
Okay. How will the patient look clinically? Look, if it is a spreading deep space infection, patient will look very sick.
Yes, sir, definitely.
Patient
You
will
cannot
look.
explain the sickness of the patient by only looking at the wound. Even if the wound is responsible for that. So actually, sickness of the illness of the patient is out of proportion to the signs of the wound. So that actually helps you to think that you are probably dealing with a case of deep space infection. Now, the treatment strategies, there are 5-step treatment strategies for a management of any surgical site infection. Number one is the pathogen identification that you have missed. So, never forget to send a
Swab
swab or
yes.
yes. So that is the first thing that should be taken as a hospital strategy. Number one. Number two, control of the source. You can just open the wound in case of superficial or deep infection, or you have to go for the drainage if it is an organ space infection. Immediate empiric antibiotic coverage, and of course, after getting, you have to de-escalate or escalate whatever the antibiotic strategy. Antibiotics, and of course that you have already mentioned, that is the local wound care. So these are the 5 steps that you have to follow in case of all surgical site infection. Doesn't matter how deep it is.
Yes.
Right. Now, the case scenario 4. A 56-year-old obese lady has undergone Whipple's procedure for carcinoma of the head of the neck.
Change straight, Dr. Ghosh.
Oh, sorry, sir. For head of the pancreas. In the evening round of post-operative day 6, she developed fever of 100 degrees Fahrenheit. Her bedside caregiver also noticed mild swelling of a left lower extremity. How will you respond in the evening round?
Yes.
How will you respond in the evening round? That is what I want to say.
Sir, I will first control. I will ask for the pain at the site of the swelling, sir, from the patient. If she complains of pain, then I will proceed with the pain management and fever control. Then I will
What do you think? What in the 6th post-op day, patient has
yes,
mild swelling in the lower extremity and fever.
Yes, sir. Yes, sir.
What is in your mind?
Sir, deep vein thrombosis or thrombophlebitis might have occurred, sir. Sorry, sir, not thrombophlebitis, deep vein thrombosis, sir.
Yes, that is one important, because do you think this patient is at high risk, mid risk, or low risk for developing deep vein thrombosis? If you take the patient scenario which is shown.
Yes, sir. It is a high risk, sir.
Why?
As because patient has undergone major surgery, sir.
One is major surgery. What else?
The age of the patient, sir, 56 years old.
What
and
else?
Prolonged immobilization.
Don't miss the next part.
Yes, sir.
She's obese.
Just follow
obese,
the first line.
Yes, sir. Obese, sir.
You have given adequate information.
And what is the diagnosis? What is the diagnosis?
Sir, deep vein thrombosis, sir.
No. Basic diagnosis for which patient underwent the operation. Because if you
Oh,
go to
carcinoma
the
head of
risk,
malignant
yes, if you go to
Yes,
the risk
malignant, sir.
stratification, risk stratification for
Yes,
deep vein thrombosis, you'll find all these points.
Yes, sir.
Patient, elderly patient, obese patient,
Obese patient,
patient undergoing
risk of
surgery for
carcinoma,
malignancy.
major surgery.
Okay,
Yes, sir.
patient having surgery for prolonged hours. And
Yes,
then
sir.
what are the other factors you take into consideration when you think of deep vein thrombosis? Any pre-op, other pre-op factors? Other pre-op factors?
Other pre-op factors, okay, sir.
Yeah.
Sir,
These are all
pre-operative
pre-op factors. Already some pre-op factors are there in the screen. Apart from this, is time of admission to time of surgery important? Time of admission to the hospital and time of surgery. Is this gap important?
sorry, sir.
I mean a long pre-op stay in the hospital. Is
Yes,
it
sir.
a
Yes,
factor?
sir. That is
Because
long
patient is
periods.
confined to the bed. Once the patient in the
Yes, sir.
hospital,
Prolonged
patient is confined.
immobilization.
Yes.
Yes, sir. Prolonged
Is one.
immobilization is definitely a cause for this.
If you take a history that patient had a episode of deep vein thrombosis in earlier period, is this patient
Yes,
a high risk or low risk?
high risk, sir.
Yes. Any history of DVT in
Any
the
history of
preceding time?
previous history of DVT is also high risk.
Okay.
Okay, sir.
So you should take into account some pre-op factors. Okay.
Okay,
Now
sir.
then you have a suspicion of deep vein thrombosis. You cannot say clinically patient has deep vein thrombosis.
No. I have to do
You have a
certain. I have to do
suspicion
labs,
of
sir.
deep vein thrombosis in the evening round,
Okay, sir. Then I will.
not in the morning round.
Okay, sir. Evening round. Okay, sir. Sir, to, sir, I would like to add, sir, low molecular heparin, sir. That is 50 units per kg of body weight, sir. IV step
50 तो नहीं होता है, 40 होता है,
50
60
units
होता है.
per kg. Oh, sir, that is Clixen, sir. Subcutaneously given. Sir, here, sir, IG I am telling, sir. 5,000 unit heparin IV, then 1,000 to 2,000 units per hour IV infusion, or 5,000 to 10,000 units 4-hourly infusion, or low molecular weight heparin can also be given like the Clixen 40 or 60 depending upon the
just
body weight.
wait. In the same
Yes,
evening with suspicion of this, you will start on full heparinization.
No, sir. Prophylactically, I would like to add just Clixen, sir. 60 or 40, sir, depending upon the body weight.
If the patient has
So
developed
actually, when
swelling,
you try to heparinize the patient in the post-operative period has undergone, you have to look what is in the brain, whether
Sir,
there
I
is
would
chance
like
of
to
getting
add
whatever.
stock.
You are not allowed. You don't
Okay.
give the loading dose of heparin.
Okay, sorry, sir.
Don't
Sir,
give the loading dose of heparin. Just
prevention is
put the
Clixen,
patient
sir,
on.
40 or 60. Then the lower limb stocking, sir. And early mobilization is also there in the for the prevention.
no. When the
No.
patient develops
The
DVT,
patient has developed DVT. Don't mobilize
No,
the
no.
patient. The
Okay.
patient will
Patient
start
has
having
developed
respiratory distress.
suspicion of DVT. The safe answer would be you can give the patient low molecular heparin rather than giving
Yes,
a unfractionated heparin. Low molecular
Okay.
heparin are safer in the post-op period. So you can give the therapeutic dose of low LMW. You can give the patient therapeutic dose because you have a suspicion of deep vein thrombosis coming up on 6th post-op day. So you
Yes,
can give the patient 60 milligram of low molecular heparin.
Yes.
Okay.
If the patient is not renal compromised, it's always safe to go with the low molecular weight heparin. If the patient has severe renal compromise, then you have to go for unfractionated heparin. And even in those cases, if the patient in the post-operative period, you avoid giving the loading dose.
Okay.
Right? Now, do you want to prove the scenario? I mean, prove that the patient is having a VT.
What
How
next
to prove
morning?
Yes, sir.
If a facility for 24 hours, you can do the same study in the same evening. What?
Sir, I'd like to go for certain investigation, sir.
Like
what investigation you want to perform?
Sir, lower limb Doppler study, sir. Or, sir, USC with
So you
color
are in the
Doppler.
bedside. You're in the bedside. Doppler study is being done. Tell us few important points in Doppler study which will suggest that patient has got a deep vein thrombosis. What are the findings in Doppler study to say the patient has got a deep vein thrombosis? So in that case, you have to know what is the normal vein looking like in a Doppler study and what is the finding in deep vein thrombosis. You put the probe over the deep vein. Okay.
Okay,
You
sir.
have to compress it.
What do you see? In the deep vein, suppose you have a color coding applied.
Yes,
What
sir.
do you find in the deep veins? You can see the flow,
Yes, sir.
which appear red or blue.
Sir, vein.
Yes, if you're putting your probe on the vein and you color code in the Doppler machine and you on it, you find this color will be flowing as red or blue.
Sir, if the probe is flow is against the the probe, then it is red, sir. And
Oh,
if it is
in the
along
vein?
the
No. In
along,
the vein, it's a vein in the leg.
yes, sir.
You put the probe over the vein and if you apply the color coding, the flow will be shown as blue in a vein
Yes, sir.
because
Yes.
the flow is away from the probe.
Away from the probe, yes, sir.
Okay, so blue.
Sir, in Doppler findings, sir,
Yes.
irregular, sir.
Then
Vein walls.
that I'm asking one thing, one by one.
Yes, sir.
One is you can see the flow, and if like coloring, it is a blue flow.
Yes, sir.
Okay.
Yes,
What else is the finding in the normal vein? One is you can see the flow. You
Yes,
can
sir.
even measure the flow velocity,
Yes,
and
sir.
you can have a color coding in the flow.
Yes, sir.
What else you look for in the normal vein? If you press with the probe,
Yes,
what
sir.
is going to happen in the vein? You press the vein with the probe. What is going to happen in the normal vein?
Sir, distal part will get collapsed, sir.
Distal part.
I mean,
You are putting the probe. You can insert only the probing
sorry,
part.
sir. Do not. Probing part. Okay.
What happens to the compressed part? The vein wall will collapse in a normal patient.
Collapse.
What
Yes,
is that called
collapse.
as? Normal veins are compressible.
Okay, sir.
Normal veins are
Compressibility.
compressible. Compressibility.
Yes,
You place the probe and ask the patient to get deep breaths. Patient is taking deep breathing, deep inspiration, deep expiration. What do you note in the vein?
compressibility, sir.
No. You have not
Collapsibility.
compressed. You place the probe over the vein and ask
Okay,
the
sir.
patient to take deep breathing, deep inspiration,
Deep
deep
breathing.
expiration. What do you find in a normal vein? What happens during inspiration in the vein? The flow increases or decreases?
Sir, during inspiration, sir,
Yes.
inspiration, the flow increases, sir.
Why? Why flow
It's
increases
because,
during inspiration?
sir, it's because the negative intrathoracic pressure, sir.
Yes.
There is increased venous
So this
return.
is known
So,
as phasic variation.
yes,
If
sir.
you place the probe on the vein, they notice
Yes,
the
sir.
normal phasic variation when the flow will increase during inspiration and dampen during
And
expiration.
decreases during
Now you
expiration.
have a patient has got deep vein thrombosis. You place the probe. What are the things you look for now? You know the normal vein. What are you
Yes,
going to
sir,
find in the patient with thrombosed vein?
then, sir, I will check for thickening of the vein walls.
Thickening means what?
I think
Previously, you are seeing the normal flow.
yes,
So
sir.
normal flow will
Decreased
not be
flow.
there, number one.
Yes, sir.
What about compressibility? There is a thrombus inside the lumen.
But compressibility will be diminished, sir.
Yes, will not be compressible. What is going to
Calcified,
happen in the respiratory variations? Even if there is some flow in the vein, it is not
yes, sir.
completely occluded. What is going to happen?
Not completely. Okay. Turbulence will be there, sir.
No, these phasic variation will get lost.
Will get lost. Yes, sir.
Okay.
Okay, sir.
Yes, Dr. Ghosh.
Sir, we have few scenarios to cover. Now this same lady actually now again sees in the post-operative day 6 has developed a fever of 101 degree. Forget about her limb problem. Now she is also having a central venous catheter in her neck. Now
Okay,
and complaining a mild slight pain in that area.
Okay, sir.
Now
Okay,
how will
sir.
you respond in this case?
Okay, sir. As because POD 6, sir, if the central venous catheter is not required, then I would like to remove the CVC and I would like to send the tip
Why?
of
Why you
the
like to?
tip.
Why you like to remove the CVC?
Sir, the infection might have, as because patient is complaining of pain in the neck, the localized.
What infection? What infection? What is the name of that infection? The terminologies must be very, you must be right with your terminology.
Infection is a
Patient
central
might
vein,
develop.
catheter,
So,
other catheter.
Catheter related infection. Yes, sir. Catheter.
Yes, it's a catheter related bloodstream infection.
Yes.
And this is actually the patient might have some sepsis, and you have to. So most common cause for catheter related infection is actually a staphylococcal infection.
Staphylococcus.
And again, in this case, I'm going a bit rapid now because of lack of time. So if it is less than 10 years, generally the infection comes from the skin through the extraluminary. But if it is after 10 days, it may be intraluminal. In these cases, actually, now what used to happen that at least one positive blood culture, not only send the tape, you have to go for the blood culture to make the diagnosis, the clinical manifestation, and no other source of any blood-borne infection. Then you have to consider that yes, you are getting a CRBSI. And if you are thinking that it is within 10 days, we're actually dealing with a staphylococcal infection, you go with vancomycin. So you have to start, right? But of course, if you remove the catheter, you have to send the tip for, you have to send the tip to probe it. Yes, right. I'm not going into the thrombophlebitis. Now, what I want to say actually that whatever, of course, for few days, for a different day of, post-operative fever, we consider some special issues. But never forget, if you are considering a fever in the post-operative day 5, even it can be a pulmonary cause, right?
Yes, sir.
For any day, you may have a thrombophlebitis or central venous line. So even if you are assessing a patient on the 6th post-operative day, you have to consider the pulmonary cause, the urinary tract infection, the wound infection, the venous trauma. So actually, you are not allowed, you have to go in a very methodical way. You have to take the history properly, and you have to examine the patient very methodically. That is the most important clue, that you have to examine the patient very methodically. A chest clinical, chest examination, inspection of the wound, inspection of the cannula sites, doesn't matter whether it is a peripheral one or a central one, examination of the legs, rectal examination. Suppose in this case of, appendicular perforation, you may have a pelvic abscess, so that can be picked up at your fingertip. Urine culture, stool culture if you are suspecting of a Clostridium difficile infection, and of course, always go for a drug sensitivity when you are having an infected source at your tip. Now, beyond checking the WBC count that we always check, that a shotgun approach to workup of the post-operative fever probably is not warranted. So don't shoot here and there actually. Always try to have a focused approach. Otherwise, the chart that I have shown, you will not be able to reach. So I already have mentioned that these are the days that for pulmonary cause, we first 48 hours. For UTI, we have to look for a 3 to 5 days, wound 5 to 7 days, and of course the DVT in the 5th days. And when you don't get any cause, never forget about the wonder drugs that I will show you one slide. And in the early first day, a mild fever with chest pain, and it may even happen. It's not always atelectasis. Just never forget the patient might have something bad in his heart also. A 30 now, this is last scenario. A 30-year lady with history of treatment for getting
next slide.
Getting treatment for Graves' disease, needed an emergency abdominal surgery during this pandemic. Now she developed high fever in the evening. Temperature is 105 degrees Fahrenheit, pulse rate 140, ECG, the monitor shows atrial fibrillation. The patient is disoriented. Now, what is your thinking in this particular case? Yes.
Yes, sir.
A 30-year lady, Graves' disease, getting treatment in the pandemic, and develop high fever. following an emergency abdominal surgery.
Yes, sir, thyroid, maybe a case of sir, thyroid storm, sir.
Yes. And what is the fever?
Fever is
105 Fahrenheit fever
very
is
high
what?
grade. Yes, sir.
You use the specific term.
What is the term?
You said
Malignant
earlier
hyperthermia.
in a different scenario.
Malignant hyperthermia.
Yes. Is a classical history. Patient has got thyrotoxicosis, underwent surgery for some other reason, or maybe for thyroid also. A patient was inadequately controlled.
Yes.
So this patient might have a thyrotoxic crisis, as well as this patient, as I have mentioned, may have a malignant hyperthermia. So you have to, what I want to mean actually, that you have to keep your eyes open. So if you have a fever in the day 0 or in day 1, the most common is, of course, is atelectasis that we all know, but always never forget that it may be a persistent sepsis if the surgery has been done to control any infection, any rare cause like thyroid crisis, any transfusion reaction, and drug fever and malignant hyperthermia. So whenever you are dealing a fever in these days, you have to look for these things. Now again, malignant hyperthermia, where there is unexplained increase in the heart rate. There was an explanation that the patient has a grave disease, but if it is unexplained increase in the carbon dioxide, rapid breathing, muscle rigidity, that is the key point that actually drags your attention to this rare phenomenon, and rapid elevation in the temperature. So you have to, and of course, you have to look for whether what anesthetic he has received. Now, so at the end, I want to mention the general principle that you have to keep in your mind. The daily or more frequent examination of the patient.
Next slide.
Daily or more frequent examination of the patient, including the surgical wound, the methodical examination, removal of all surgical tubes as soon as possible. That includes rice tube even. A rice tube can cause sinusitis and can cause fever. Early ambulation of the patient, because I have already told that prevention of post-operative complication is probably the best treatment available for post-operative complications. Close monitoring of the fluid balance and electrolyte that we always do. Adequate pain management is absolutely necessary, and of course a good care, that means a good nursing care that can actually avoid many post-operative complications that we have discussed. That includes the mobilization of the patient, prevention of deep vein thrombosis, prevention of UTI, prevention of catheter-related blood-borne infections. So these all things can be addressed by giving good nursing care. Thank you.
Thank you, Dr. Ghosh, very much for
Thank
the
you, sir.
nice different case scenarios. It's my pleasure to welcome Dr. Bhavin Patel. Dr. Patel, any comment from your side for today's discussion? Dr. Patel, can you hear us? It was a nice discussion. We have covered almost, in fact, we don't discuss so much on each of the aspect, but Dr. Ghosh has given a very good scenarios of different case where you have addressed all the causes of post-op fever. So approach to each of these. We should always keep in mind the broad outline of causes of fever and their management. And then if the examiner is very specific about particular scenario, it may be what around that patient is lying in front of with a swollen leg and post-operative. So it's basically a deep vein thrombosis. So confine your attention more towards deep vein thrombosis and always keep your mind open for other causes to be discussed in the particular scenario. Don't be very rigid that only the deep vein thrombosis is the cause of fever in this patient, because patient with major surgery may have multiple causes for fever. So if you're obvious of deep vein thrombosis, confine to that main part, but you should always be ready to, the point was not shotgun approach for investigation. It should be a comprehensive clinical assessment. So if you find clinically there is no chest symptom, patient is otherwise fine, saturation maintaining, there is no point asking for CT scan of the chest. Okay, so it should be a good clinical evaluation followed by relevant clinical investigations and confined to the primary suspicion of the disease which might be the cause of fever. Okay, so you have a very good discussion. Any comment from any of or faculties? Thank you, Dr. Ghosh. Thank you very much.
Thank you.
Thank you,
Thank you.
Thank you, sir.
Thank you.